Lymphatic system, lymphadenopathy, definition, lymph node enlargement, etiology, inflammatory, acute and chronic, acute, non-specific, and specific as infectious mononucleosis, chronic, non-specific, specific as TB and syphilis, metastasis, lymphomas, Hodgkin and non-Hodgkin's lymphoma, blood diseases, acute leukemia, chronic myeloid leukemia, and chronic lymphatic leukemia, lipoidosis, Gutcher's disease, Niemann-Pick's disease, and Hand-Schüller-Christian's disease. Functions of the lymphatic system include uptake, transportation, and return of fluid, foreign substances, and macromolecules from the interstitial space to the systemic circulation, protection of the host by filtration system which resists infection and impedes spread of neoplasm, secretion of T cells, B cells, cytokines, vascular endothelial growth factors which stimulate lymphangiogenesis, inflammatory disorders, acute lymphangitis, definition, inflammation of the lymphatic vessels, etiology, commonest organisms are streptococci, clinical picture, general, fever, rigors, general constitutional disturbances, local, pain, edema, red tender streaks, regional lymph nodes are enlarged and tender, complications, complete obliteration of the affected lymphatics, and if the condition is repeated or involves major number of lymphatics draining an organ or a limb, permanent edema or lymphangiasis. Treatment of the cause, antibiotics, especially penicillin and broad-spectrum antibiotics, local rest of the affected part and local heat to help resolution. If suppuration occurs, it needs an incision. Acute septic lymphadenitis, definition, inflammation of lymph nodes, etiology, along the lymphatics, from inflamed focus. Clinical picture, the picture of the causative lesion, general constitutional manifestations. Locally, the nodes are enlarged, red hot and tender, firm or soft, and if suppuration occurs, they become fluctuant. Treatment of the causative focus, general rest and antibiotics. If an abscess forms, incision and drainage. Complications, spread to proximal lymph nodes, spread to nearby tissue, suppuration leading to abscess formation. Chronic non-specific lymphadenitis, site, submandibular and inguinal lymph nodes, clinical picture. Nodes are slightly enlarged, mobile, tender, and firm in consistency. Treatment of the cause. If persists for more than 3 or 4 months, TB must be excluded. TB lymphadenitis, types, lymph-borne, common in young, blood-borne in elderly, site, lymph-borne, fibrocaseous type, the commonest, cervical lymph node groups, commonest, the organisms reach the tonsils, from the tonsils, mediastinal and axillary groups, especially in children, plus or minus TB lesions in the lung, abdominal lymph nodes, children and adolescents, organisms from the ingested milk pass through the lacteals to reach lymph nodes without affecting intestinal wall. Tabes mesenterica, more than 50 years, common finding in X-ray, is multiple mottled calcific shadows of mesenteric lymph nodes, old TB nodes healed by fibrosis and calcification. Pathophysiology, the organisms reach lymph nodes by afferent lymphatics, so reaching the capsule first, TB periadenitis, matting of the nodes, then the cortex will be affected, and finally the medulla. Multiple tubercles will form, coalesce together, may caseate and break down, leading to cold abscess which may rupture through the skin, leading to TB sinus and ulcer. So we have comparison between the lymph-borne type and the blood-borne type of TB lymphadenitis. For the lymph-borne type, we have incidence, common, age, children, local signs, localized lymphadenopathy affecting upper deep cervical lymph nodes, variable consistency, earlier, firm, caseation, cystic, calcification, hard. Lymph nodes are matted together and they may be arranged in beaded cords due to thickening of the connecting lymphatics. Caseation, cold abscess leads to TB sinus. Blood-borne type, the incidence is rare. Age, usually elderly. Local signs, generalized lymphadenopathy, firm inconsistency, and lymph nodes are discrete, and the patient is usually an adult of fair resistance, so there is no breaking down, caseation, or cold abscess. Caseation, no cold abscess, and no sinus. Complications may burrow through the deep fascia or an overlying muscle, bilocular, Kohler-Studd abscess. Secondary infection may occur leading to difficult treatment. Cold abscess is actually neither cold, clinically warm, nor abscess. Contents are not pus but caseating material. Sinus with a thin cyanotic undermined edges and thin serous discharge. Spread to other groups of lymph nodes if the disease is left untreated. Investigations, chest X-ray, tuberculin test, good negative indicator. biopsy from the nodes, establish diagnosis, aspiration of cold abscess for microscopical pus exam, smears from a sinus, and examination for tuberculous organisms. Treatment: tuberculous lymphadenitis before caseation, good diet and vitamins, at least 2 anti-tuberculous drugs, rifampicin and INH, for at least 9 months, surgical excision for single lymph node group with no response to medical treatment after 6 months, cold abscess, anti-TB drugs, aspiration and injection of streptomycin solution to prevent sinus formation. Needle is inserted in a healthy part of the skin away from the abscess. The site of puncture should be in a non-dependent part. The needle should pass in a valvular manner. Points of entry through skin and abscess cavity shouldn't be opposite to each other. Aspiration usually needs repetition every few days until abscess dries. Incision indicated in the following conditions: secondary infection if the abscess is imminent to rupture, excision if the nodes need excision. Treatment: treatment of the tuberculous sinus, anti-TB treatment, dressing with streptomycin powder every 3 days until it closes. If resistant to conservative measures, excision with underlying nodes. Chronic lymphatic obstruction or lymphedema, hypertrophic skin and subcutaneous tissues caused by chronic lymphatic obstruction, sites, limbs, lower limb lymphedema, post-mastectomy, upper limb lymphedema, most common. Others, scrotum, external genitalia, and rarely breast. Etiology: primary lymphedema, secondary lymphedema. Primary lymphedema, congenital malformations of the lymphatic vessels. Types: we have lymphedema congenita, lymphedema precox, and lymphedema tarda. Lymphedema congenita incidence 10%, while precox 80%, tarda 10%. Age for congenita at or within first year of birth. Precox usually adolescents, and tarda after 35 years. Sex: males more than females in congenita, females more than males in precox, and males equals to females in tarda. Site: commonly bilateral and involving the whole leg. For the precox, commonly unilateral and below the knee, while in tarda, usually unilateral. Secondary lymphedema, common. Post-traumatic injuries as circumferential skin loss, operations as extensive blood dissection of regional lymph nodes, irradiation of the regional lymph nodes. Parasitic, filariasis is the commonest cause in Egypt. Post-inflammatory, recurrent nonspecific lymphangitis, recurrent cellulitis, interdigital infection, and chronic leg ulcer. And post-erysipelas lymphedema. Neoplastic, primary affection as lymphomas, secondary affection by metastasis. Pathology: the patient with lymphatic obstruction suffers from 2 problems: lymph stagnation and recurrent attacks. Lymph stagnation, accumulation of large amount of protein-rich fluids, irritant in tissues, leading to foreign body reaction, fibrosis in subcutaneous tissues, leading to more obstruction. Recurrent attacks of lymphangitis, leading to more obstruction, and this is a vicious circle. Pathological changes: swelling, edema, and skin changes. Swelling, first due to accumulation of fluids and later due to fibrous tissue. Edema, pitting, then later non-pitting fibrosis hardens the skin. Skin changes, negligible in primary lymphedema, but in long-standing cases there is thickening, hyperkeratosis. Lymphatic vesicles may appear in the skin. In severe cases, the skin develops huge bulges, elephantiasis. Clinical picture: type of the patient according to history of the cause. In filariasis, adult patient from an endemic area, Giza, Imbaba, complaining of progressive leg swelling with exacerbations and partial remission. During exacerbations, attacks of streptococcal lymphangitis, the limb shows red tender streaks traveling to draining lymph nodes. The swelling is hard, non-pitting, with a crease in front of the ankle. And in late cases, skin may show blebs, which may rupture. Superficial ulcers oozing lymph, lymphorrhea. Skin is dark, thick, with multiple deep furrows, thick callosities, and warty overgrowth, such as elephantiasis. The inguinal lymph nodes may be enlarged, firm, and tender, chronic septic lymphadenitis, or soft lobulated mass, varicose lymph nodes. Other filarial manifestations as lymphedema of scrotum, filarial funiculoepididymitis, chylocele, rupture of lymphatics in tunica vaginalis, and chylous ascites and chylothorax. Differential diagnosis of chronic diffuse limb swelling, post-phlebitic limb, elephantiasis, neurofibromatosis, congenital AV fistula, local gigantism, and finally, lipodema. Filarial lymphedema of the lower limbs. Most common cause in Egypt is infection with Escherichia bancrofti. Disease is endemic in Egypt in areas near the Mediterranean, such as Dumyat, and in areas at the desert edge, Giza, Sharqiya, and Asyut. Etiology: obstruction of the lymph nodes by adult worms, leading to stagnation of lymph and dilatation of the lymph vessels. Investigations: midnight blood film for microfilaria, intradermal skin tests, lymphoscintigraphy, a nuclear medicine study of lymph vessels and nodes. Radio-labeled particles of proteins are injected just under the skin. Near-infrared laser fluorescence imaging uses, such as indocyanine green, imaged with infrared fluorescence camera, lymph vessels and nodes can be visualized. It's a dynamic study analysis of the lymph flow. Magnetic resonance lymphangiography by injection of contrast subdermally to visualize the lymphatic system, lymph vessels, and nodes. Evaluate lymphatic obstruction by size, function, and dermal backflow. Ultrasonography to evaluate edema and fatty tissue in the limb. Treatment: conservative treatment, limb hygiene, elevation, manual massage, exercises, weight loss, compression, garments, plus or minus intermittent pneumatic compression, elastic stockings used permanently to after reduction of the size, diuretics which are of controversial value, long-acting penicillin 1,200,000 units for every 3 weeks, diethylcarbamazine active filarial infection, surgical treatment for severe cases, physiological operations to improve faults in lymphatic drainage of the limb, indications: early stages where imaging shows dilated lymphatic vessels, types: lymphovenous shunts, lymphatico-lymphatic bypass to bridge the obstruction with lymphatic graft, autologous lymph node transplantation to stimulate lymphangiogenesis, excisional operations to reduce the bulk of the limb by eradication of swollen, diseased tissues and skin with closure of the defect with skin flaps and grafts, liposuction to treat residual swelling, lymphomas. Definition: malignant neoplasm which arises in lymph nodes or extranodal lymphoid tissue, types: Hodgkin and non-Hodgkin, and finally Burkitt's lymphoma. Hodgkin lymphoma, more common pathology, gross picture, site lymph nodes and extranodal tissue in spleen, liver, and bone marrow, starting in cervical lymph nodes. Affected nodes are enlarged, discrete, rubbery, have pink color. Large lymph node in the center with small lymph nodes around it. Microscopically, there are variable densities of lymphocytes. Diagnostic feature: finding characteristic Dorothy-Reed-Sternberg cells, giant cells with even number of nuclei, 2 or 4, arranged in mirror image. Types: lymphocyte predominance. Giant cells are rare, but there are abundant lymphocytes and histiocytes, and this type is of the best prognosis. Nodular sclerosis, the commonest type, characterized by broad fibrous bands which disrupt the lymph node architecture. Mixed cellularity, heterogeneous cellular component of eosinophils lymphocytes, plasma cells, and giant Reed-Sternberg cells. Lymphocyte depletion, considerable fibrosis, variable amount of Sternberg cells, and few lymphocytes, and this is of the worst prognosis. Staging: 1, 2, 3, 4, 1, single involved lymph node group 1, or single extralymphatic site, i.e. Stage 2, 2 or more involved lymph node groups limited to one side of the diaphragm, or a solitary extralymphatic site and one or more lymph node areas on the same side of the diaphragm, and this is called 2E. Stage 3, involvement of both sides of the diaphragm. Stage 4, extralymphatic spread, including liver, bone marrow, skin, and gut. All stages are subdivided into A, no systemic symptoms, and B, one or more of 3 symptoms: fever, night sweats, or weight loss more than 10% in 6 months. Clinical picture: incidence: Caucasians are affected by Hodgkin more than other races. Disease shows 2 age peaks, first between 15 and 35, and the other more than 50 years. Symptoms and signs: painless progressive enlargement of the cervical lymph nodes, this is the most common. With progression of the disease, other node groups in the neck, axilla, groin, mediastinum, and abdomen are affected. These nodes are enlarged, discrete, non-tender, and rubbery in consistency. Splenomegaly and hepatomegaly may also be present. Some patients exhibit systemic manifestations as a form of fever, night sweats, weight loss, pruritus, anemia, and jaundice, sometimes characteristic intermittent fever which lasts for a few days, followed by remission for a few weeks, occurs, and this is called Pill-Epstein fever. Immediate pain in diseased areas after drinking alcoholic beverages. Investigations: full CBC, anemia, high ESR, eosinophilia or lymphopenia, alkaline phosphatase elevated in cases with bone or liver involvement, lactic dehydrogenase and beta-2 microglobulin, usually elevated, chest X-ray and CT scan detection of intrathoracic disease, abdominal ultrasound and CT scan to detect intra-abdominal disease, lymph node biopsy under general anesthesia. This is the cornerstone of diagnosis. The site of biopsy, neck, inguinal nodes are better avoided as they are commonly enlarged as a result of chronic nonspecific lymphadenitis. Bone marrow biopsy, immunophenotyping, technique of identifying molecules associated with lymphoma and leukemia cells that help identify their subtypes. Treatment, stage 1A, 1B, and 2A, radiotherapy to affected and adjacent group of lymph nodes. Stage 2B, radiotherapy and 6 cycles of combination chemotherapy. Stage 3 and 4, 12 cycles of chemotherapy. Radiotherapy is used as a supplement to control bulky cervical nodes. Chemodrugs, doxorubicin, bleomycin, venblastin, and dacarbazine. Prognosis, 80%, 5 years survival with treatment, and 100% for stage 1A with lymphocytic predominance. Non-Hodgkin's lymphoma. Classification, each type of the cells may be arranged in nodular or diffuse manner. B-cell lymphoma, 80 to 85%, is further classified into immunoblastic lymphoma, small cell lymphoma, large cell lymphoma, mixed cell, small and large lymphoma, T-cell lymphoma, lymphoblastic lymphoma, histiocytic lymphoma. Etiology, the exact cause is unknown, but increased incidence with Sjogren's disease and benign lymphoepithelial lesions of the salivary glands, immune deficiency, AIDS with prolonged immune suppression, human T-cell leukemia, lymphoma virus, HTLV1, and systemic lupus erythematosus. Clinical picture, lymph node enlargement is similar to that of the Hodgkin's disease. Progression of lymph node enlargement. Non-Hodgkin lymphoma is more likely to affect extranodal sites than Hodgkin's lymphoma. Gastric lymphoma produces manifestations which are similar to carcinoma. Intestinal lymphomas leads to intestinal obstruction, bleeding, or perforation. Mycosis fungoides, variant of non-Hodgkin lymphoma affecting skin, having eruptions. The disease is likely to be disseminated at the time of presentation. Treatment, radiotherapy and combination chemotherapy. According to stage, common drugs are cyclophosphamide, adriamycin, vincristine, bleomycin, and prednisolone. Surgery indications, gastric and intestinal affection. Method, gastrectomy and intestinal resection, followed by radio and chemotherapy. Prognosis, gastric lymphoma better than gastric adenocarcinoma. Burkitt's lymphoma, unknown, maybe infection with Epstein-Barr virus. Malaria may have a role to induce the disease. Pathology, malignant tumor of the B lymphocytes. Type of the patient, male, less than 12 years in Western Africa. Clinical picture, painless, progressively enlarging jaw with swelling. Distorts face, displaces the eye, and partially occluding the mouth. Treatment, chemotherapy, cyclophosphamide, and cytosine arabinozoide. Leukemias. Definition, generalized enlargement of lymph nodes, spleen, liver, with marked increase in total leukocytic count, mostly made of immature forms. Chronic myeloid leukemia and chronic lymphocytic leukemia. Chronic myeloid leukemia affecting both genders equally between the age of 35 and 70 years, while the chronic lymphocytic leukemia affecting elderly people, especially males. Myeloid leukemia, onset is hideous. Symptoms, anemia, weight loss, spontaneous hemorrhage. Signs, nodes are slightly enlarged and discrete. Marked splenomegaly, hepatomegaly, and generalized lymphadenopathy. While of the lymphocytic leukemia, moderate enlargement of all lymph nodes and lymphoid tissues, but spleen is much smaller than the myeloid leukemia. Investigations for the lymphocytic leukemia, CBC showing moderate anemia with great increase in white count up to 500,000 per cubic microliter. 80 to 90% are immature lymphocytes. Treatment, chemotherapy, biological therapy. Prognosis, 5-year survival is about 80%. While investigations for the chronic myeloid leukemia, CBC, progressive anemia with increased white cell counts up to 1 million per microliter. 80 to 90% of them are immature with granular serous. And this concludes the lymph.